This is the Healthcare Marketplace Specialization, Healthcare Marketplace Overview. My name is Steve Parenti, and this is Module 5.2.3, Insurer Information Technology. So, health insurance companies face what I call an insurer's IT paradox. We know it's important as an academic when we start thinking of things as paradox, and it's not a space-time continuum Star Trek sort of problem. So what do we mean by this? Insurers are being held accountable for an insured patient's total care. If something goes wrong with that patient and they're insured, the insurance company will be sued. Not just the physician, but the insurance company likely will be sued if there's an issue. Now, what's great about an insurance company is they have the best breadth of data. They see the data from all places of service because of the billing records, and that data is actually very standardized. It has a very common structure that can be used and seen across different areas. The problem is that it has the worst detail. There's very little clinical information on what the patient's health status is or their outcomes. For example, we know that a clinical test is being billed for, but we don't actually know the outcome of the test. Literally, someone could be billing for a test for cancer. We don't know whether it's benign or malignant in terms of what the test results are going to be. And so this presents a paradox. They're linked to all of it, but yet they don't have sufficient data to manage. Insurers have a major role in health IT. They are the links that connect pretty much everything about a patient in an electronic form. They also link to employers because of the large role that employer-sponsored health insurance plays in America. It links to providers, whether it be nurses, physicians, hospitals, and such. Patients, obviously, to get their information online or by calling in different pieces. Government agencies because of their financing role as well as their regulatory role that have to give information back to the insurers. And then researchers that either work for the insurers or actually are working for Medicare, which is another form of insurer, to look and see how health IT is telling people how well the plans are actually working. So we've talked about this before in our marketplace overview or our landscape picture, really. We have actual e-links that are there. We see the linkages that go across between the insurance company to the hospitals and then also between the insurers and the physicians. There's a link sometimes that go in between the hospitals and physicians if they're owned by one another in terms of transfers, but most of this information is really billing information. And the other thing to keep in mind is that it's not necessarily instantaneous. If there's a pharmacy that's inside the hospital or a freestanding pharmacy, say somewhere out in Main Street, that might actually get connected to the insurer in terms of payment. And that could be close to real time. But much of the time that the payment information for the insurers, while it's standardized, it's frequently delayed. Physicians could take as much as 30 up to 90 days to get their bills paid for by the insurance company. And that's a pretty long time horizon, actually. So another thing to keep in mind with insurance data is this concept of what it can actually reveal. And one of my past jobs was to actually look at this data and sort of identify to what extent we could see whether, say, a physician was doing a good job managing a patient. So in this one instance, we have one patient that we're focused on here, and that patient has some mental health issues. They're depressed, and we can see that they've been getting psych consults periodically throughout a calendar year. There's a gap here that went on, and so one thing that say an analyst would have to look at is to look at the cost for this given patient and sort of say, are they being managed very well? And they might say, my God, their costs are huge. They go from $0 to $50,000 here. And what's really going on here with this little bump here? They keep going up and up. And what you don't know and what's so frustrating is that if you had more clinical data and clinical notes or some other pieces, you would realize, and actually this is almost impossible to do, we don't really have implantable mental health sensors in us yet. But if we had data, say, on the person's actual mental state, we see that they were varying all over the place and actually take a deep dive in terms of being very depressed. And what actually drives all of this cost going up is this event here is actually an inpatient event where they basically get admitted and then they have a psych consult as a result of that. And then after that psych consult, they seem to be doing better to the point where they're actually fairly stable here, not nearly as bad as they were off, but are being seen repeatedly. And so the question comes up to an insurance company, like, well, is this doctor or this team really caring for that patient well? And on the one hand, you're like, well, costs are going up, but, we're not quite sure why this gap occurred. Maybe it was the patient. Maybe it was their mental health professional here wasn't really, maybe putting them on the right pathway. But what we do see is that now that the interventions has occurred, it's all costs are a little incrementally higher. The person's doing better and they're avoiding the inpatient stay. So maybe it might not be so bad. This is what makes working with this data so challenging. What makes it even more challenging is that it's pretty limited information. This is a form that's actually used by CMS. It's called the HCFF 1500. Now it's the CMS 1500 for Centers for Medicare and Medicaid Services. It's almost like an SAT test. It has basic information here, like here's my name, here's my address, here's my status, where's my insurance company's name, what's the other dates that I'm there. But really the inciting stuff is this stuff here, diagnosis code. And actually, you have up to 4 spaces, 1, 2, 3, 4, to write a 5-digit code that best represents what the physician sees and they think that's wrong with you. They may not know until they actually do the testing, and so you got to be careful about using this information. But that's where the diagnosis goes in. There's a date of service that goes in here. There's this thing called CPT, which stands for Current Procedural Terminology Version 4, which is a procedure code. There's a modifier saying is it left or right eye or something else that might be additional information about that procedure. Again, they write down a diagnosis code for why they're doing that procedure, whether it's a lab test or, say, a surgery. The charge information, which may have no bearing on what they're paid, but it's what they would like to get paid if they're a physician, and then some additional information, how many units, say, that are in play. So when we look at what is actually inside an insurance claims database, this is a very high level. You really need to be taking a more focused course if you want to go deeper into health IT, but these are really the basic pieces. There's a claims management system that basically is keeping track, almost like a checkbook system, on debits and credits and what claims are coming in. There's membership data to know who actually is in your insurance population. There are provider files to know where to cut checks to and to see what credentials the physicians have. There are also additional files that look at focusing on managing the patient's care, and then additional financial data that actually is very helpful for the insurance company to manage its own portfolio, given the risk it's assumed. If you ever work with claims data, things you need to know, a lot of it is electronically. Actually, 85% or more of it is electronic. The key things you're going to want to look for is the date of service, and as well as the claim ID, who actually is getting the service, if they're a member of the health plan, what's their ID code, who is the actual provider of that service, a hospital, physician, pharmacist, for example, what diagnosis and procedure are there, what are charges, what are also how much the physician really gets paid, what does the patient pay through copays or coinsurance, and any other administrative information that might talk about what else is happening in that claim. This is an illustration of what claims data can look like. It's a little bit like what you might see with sort of information for, say, a checkbook account. Here we actually have encrypted study IDs. A lot of times they're social security numbers, this piece that's here. We have real birth dates. We actually have, in this case, start dates. These are years and then months and days. Here we have charge information, and this is actually inpatient data. So this is someone who's literally basically asking to be paid $13,146 for an inpatient event. What's interesting is that they want to be paid that, but the insurance company pays them only $3,344. There's actually a Medicaid plan that does this. This is their hospital ID. We know what the procedure codes that were done. We know the diagnosis codes. That's probably diagnostic here. We know when they were discharged as well as they were admitted. So then we can see how long they were there. LOS stands for length of stay. It could be 6 days, 3 days, 1 day. And it doesn't always have a bearing on how much the cost will be. There might be quite less, and sometimes there's the copays that go back to the patient. So very detailed information, but this is sort of the bread and butter of how a lot of insurance companies look at their costs as well as analytics manage it. This concludes our module on what the insurers have for health IT.